because then we are going our basic scientists are going to be highlighted. So those are the upcoming events in Europe right now, especially on the North American part of the world. So the next month we're going to be having UCSF going to be talking to us. But for today, again, thank you for joining. We are 3 minutes in. I will just go ahead and start the introduction. So today, like I said, we have Professor Salma who and her team, and I'll be introducing the Professor Salma. She needs no introduction. Everybody knows her. There was a time she was a VP. She had my job. And she has been instrumental in the things I've been doing and the activities and the successes of this position and being able to move Yorick forward on the continent. So she's a professor of cell biology at University of Florida Health Cancer Center, and she continues to co-lead the Cancer Control and Population Science. And she has held prestigious fellowships from the Walter Cancer Institute, AACR Research Foundation of America for Prevention Research, and also the NIH and NCI. So her research focuses on breast and cervical cancer disparities, especially in African and minority populations. And her lab is also developing a point of care testing for early cervical cancer screening in low middle income countries. And this is the premises of what she's going to be talking today. So again, Professor Salma needs no introduction. Of course, I'm going to be introducing and she's going to continue this conference whereby she will be introducing and coordinating her team members. Thank you. And thank you for joining us, Professor Salma. I really, really appreciate it.
Thank you, Biola. Thank you for this nice introduction. Good afternoon, everybody. As mentioned, my name is Salma Mohammed, and thank you very much for joining us today for this webinar, which is titled Progress in Cervical Cancer Screening, Bringing Detection to the Point of Needs. So this event brings us here at bring Purdue University and recently University of Florida and Zambia Cervical Cancer Prevention Program. And we are here in one mission is to develop point of care tests for early detection of cervical cancer. And we are focusing on the middle income countries and rural areas in the United States. I am really, really honored to be joined with my colleague from Purdue University, Dr. Jacqueline Linus, who is Martha E. Gross Associate Professor in Weldon School of Biomedical Engineering at Purdue, and she held a courtesy appointment at the Public Health, and she received her PhD in Engineering and graduate certificate in Global Health from the University of Washington. Her credential is too long that I cannot complete everything here or we're gonna run out of time. And then I'm joined also by Dr. Samson Chesley, who is a consultant obstetrician gynecologist and oncologist at the University of Teaching Hospital, Women and Newborn Hospital in Lusaka, Zambia. And then I'm joining our fabulous, bright graduate student, Dr. Sabrine Habani, who's pursuing her PhD right now in the Department of Comparative Pathobiology, and she holds a degree in medicine and surgery from Sudan. And she worked as a medical doctor at Khartoum Breast Care Center. And then joining with Sarah Jalali, she's a PhD student in Weldon School of Bioengineering at Purdue, and she received her bachelor degree in chemical engineering and master in biomedical engineering in Sharif University Technology at Tehran. And lastly and not least, we are joining with Lucy Turtle. She's originally from Ethiopia, and she's a candidate in biomedical engineering at Purdue University as well. And so by that, we all working together in this point of care test so we can deliver accurate, affordable, and accessible diagnostic tool to the community that need the most. In this webinar, we will highlight the progress we made in this project and the challenges we faced and how did we solve them, and the exciting future for our cervical cancer screening at point of care. And by that, I'm thrilled you guys to be all with us here, and I will hand the floor to Dr. Jackie to start this presentation.
Thank you, Professor Silma. This is really great to be here, and I appreciate the opportunity. We're going to talk in this webinar into a deep dive in our project in developing solutions for cervical cancer. You all probably know better than me. I'm just an engineer, but in cervical cancer, there are 604,000 new cases every year. It's the leading cause of death in 36 different countries, and 94% of those deaths are low and middle income countries. So this is a major challenge that the World Health Organization has developed elimination targets for to be able to achieve in 5 years from now, to have 90% of individuals vaccinated for HPV, 70% of individuals with cervixes screened, and 90% of any of those people who come up positive treated. We're focusing on the second two of these in the diagnostic space for test and treat strategies. And next slide. The goal of our work is to develop an accessible and accurate cervical cancer detection for screen and treat implementation. The solutions right now are not accessible. For example, pap smears that are done by histopathologists in centralized laboratories, or lack sensitivity and specificity, for example, VIA screening and treatment. And so through an ongoing partnership since 2019, when Dr. Mohammed came to me with some biomarkers that she was excited about looking at, and through some seed funding and now NIH funding through the National Cancer Institute, we've been working on this together for the past few years. The concept is that we are able to then detect these biomarkers through a device that my research group has designed. And if you click the animation, it should pop up. The idea is that you can collect a sample from the cervix, lyse the cells to be able to access the protein biomarkers, and then put them on this little paper-based device that you add some buffer in the sample, you fold it over, and then you can detect 4 target proteins that increases both the sensitivity and the specificity of this. And then when you see that there is a high chance at positivity, you're able to visualize and treat this through screen and treat processes on site. Now, there's a number of challenges that we knew about or have learned about in the process of developing this technology. First off, which we knew was going to be feasibility. Is this something that healthcare workers want to and are even able to run with the time and resources that they have? And Dr. Sampson's going to be able to speak to this. The biomarker availability. We know that there are these proteins that exist in histological samples because they get stained for them, but we don't know if there are enough target proteins to actually be able to detect them. And Dr. Samrin will speak about this a bit. Also, biomarker accessibility. We're collecting these with a swab. We are not taking tissue samples. So can we get the proteins, sufficient amounts of them, and be able to use them in our device? And Soya is going to speak to this. Then the actual test design, which is where we initially think about in our engineering, is can we detect them in the ways that we thought we would? And Lucy's going to speak towards that test design. And finally, interpretation. We knew this might be a challenge when we started this proposal, but we've come to realize that the ability to detect 4 different biomarkers and a control by eye is not something that the human is capable of quantifying. So Soya has brought in machine learning algorithms that are able to do this interpretation beyond what we could do alone, and to be able to implement these into resource limited settings. So with that, I'll let the team tell you about the work.
Okay, thank you. Thank you very much. As already introduced, I'm Samson Chisele. I come from Zambia. Zambia is a country in Southern Central Africa with a population of just about 120 million, with a GDP per capita of 1,300. Zambia is considered a low-income country, and the HIV prevalence at the moment is around 11.1%. Next slide, please. Thank you. In terms of the background to cervical cancers, cervical cancer in Zambia is the leading cause of cancer deaths among both the men and women. In terms of its incidence, as at 2022, 3,161 was the incidence, and with a mortality of 1904. It ranks the first in terms of incidence in all years. It also ranks first in terms of incidence as well as mortality in the 15 to 44-year-olds. The current status of cervical cancer screening in Zambia is that we have been using visual inspection with acetic acid, followed by treatment with thermocoagulation or LEAP. But this is a test that has very low sensitivity and specificity. And so what the country has done in the last 3 to 4 years is to adopt the WHO cervical cancer elimination strategy by introducing HPV DNA testing, which has been partially implemented. And so at the moment, we've got around 350 or so VIS screening sites spread across the country, and about 900 HIV-based collection sites, supplemented, of course, by 165 LEAP treatment sites all across the country. Next slide, please. So despite this capacity, we've got diagnostic challenges as it comes to the HPV-based DNA testing. The main problem or gap being that we do not have a point of care HPV DNA testing. And so this makes it difficult for us to implement, the screen and treat model as recommended by WHO. So what happens is that treatment decisions are actually based on VIA results while awaiting HPV DNA confirmation. And so women who will later be found to have positive HPV DNA results are then recalled. And this is also a gap in terms of our diagnosis, because the recall rate for our patients is not high. In our studies, we have shown in our country that the recall rates could be as low as 35 to 45%, meaning over 50% of women may not sometimes return for their results. And there are also other limitations to the HPV-based platforms, including lack of specificity. Okay, they are resource intense. And then, of course, I just mentioned the need for patient recall is problematic. Next slide, please. And so moving forward, we strongly think that we could benefit as a country from alternative point of care tests, like protein biomarker based tests that is, sensitive, that is specific, that is cost effective, that is user friendly, and also that removes the need for patient recall. Thank you so very much.
Hi everyone, thank you for joining us today. I will be talking about cervical cancer biomarkers and how we can use them to improve screening and early detection. My name is Samreen Habbani and I am thrilled to be part of this project. So what do we know about biomarkers? We know that biomarkers are essential across many areas of cancer care, from screening to diagnosis, early detection, and prognosis as well. In this project, we are focusing on 4 specific biomarkers that are known for their overexpression in both cervical cancer and precancerous lesions. These include TOP2A, which stands for telomerase 2 alpha. It's a protein that's involved in DNA replication and cell proliferation. Second, we have MCM2, mini chromosome maintenance complex component 2, which is important protein in initiation of DNA replication. We have VCB, pulsing containing protein, which is involved in several important cellular processes, include protein degradation, cell cycle regulation, and stress response. And finally, we have cycling-dependent kinase inhibitor 2A, or B16INK4A, which is a well-established indicator of HPV-driven transformation. Next, please. So to understand where the biomarkers can really make an impact, we need to look at how cervical cancer can develop over time, starting from changes in the cervical epithelium. It's typically begin with normal cells and progress through stages of epithelial abnormalities, starting from low-grade changes known as LSIL, and then moving to high-grade changes or HSIL. So these abnormalities reflect the severity of dysplasia in the cervical epithelium, which are classified histologically as scene 1, scene 2, and scene 3. If left untreated or unmanageable, the high-grade lesions can eventually progress to invasive cervical cancer. These stages also correspond to cytology categories, which we use in clinical screening, which are also we also use them in our study. These categories include NILM, which stands for negative for interepithelial lesion or malignancy, ASCUS, stands for atypical squamous cell of undetermined significance, LSIL, and HSIL. This all is the common categories that used in Pap smear, and we use these categories to study the expression of the target biomarkers. So in this project, we analyzed 80 clinical samples collected using liquid-based cytology, which is the same method used in routine Pap smearing. We measured the levels of our 4 target proteins using ELISA, and each protein expression was normalized to beta-actin to account for sample variation. Out of these 80 patients, we had 21 cases, which was normal or negative, and we had 57 cases that had abnormal Pap smear results, including 33 cases ASCUS, 12 cases LSIL, low grade, and 12 cases were high grades. So although we measured all the 4 biomarkers across different sample sets, for the sake of time, I will focus in this slide only on MCM2 and B16. So on your left side, you see the expression of MCM2 across the different clinical categories. And while there is some variability, we observe an upward trend, particularly in the high-grade cases compared to others. In your right, you see a result of B16INK4A, which shows a clear and statistically significant changes starting from normal, rising through the low-grade and high-grade lesions. So by these results, suggests that these 2 proteins, MCM2 and B16INK4A, may be valuable when used in combination with other biomarkers for screening or early detection. So in summary, I did not show all the results here, but all the 4 biomarkers were evaluated, and they showed potential strong candidate for identifying the high-risk cervical cancer lesions. So using these liquid-based cytology samples, we were able to detect consistent biomarker expression patterns, and we are looking for the future of this project. So thank you for your attention, and I will be now handed over to Saya.
Hi, everyone. So happy to be here today, and thank you for this great opportunity. Today, I will be talking about sample collection, release, and processing. So the collection technique that we're going to be using is similar to Pap smears. As Dr. Cicely mentioned, the gold standard in Zambia currently is either VIA, and HPV DNA testing is partially being implemented there. However, Pap smear testing has been the gold standard in more developed countries, including the US, and we're taking a similar approach in terms of collecting the sample. So as you all may know, it starts with cleaning the external cervical OS with betadine to remove any contaminants, and then inserting the swab or the sampler of choice 1 to 2 centimeters deep into the endocervical canal, and then rotating it 5 times in one direction to collect the endocervical cells. And prior to taking it out, we will scrape the ectocervix to get some of the squamous cells, and then without touching the vaginal walls to avoid any contamination, we will take the sampler out. In terms of releasing and processing the cells, we took a different approach. So instead of releasing it in a transport media such as ThinPrep or SurePath, we have decided to directly release it in our lysis buffer. Why did we choose, we need a lysis buffer to begin with? It's because the 4 proteins that Samron mentioned are all intracellular, so we need to access them, and that's why we need to lyse and break down the cells to get access to those proteins. After screening 5 lysis buffers, we've chosen REPA, which is short for radioimmunoprecipitation assay, and the way we optimized the process to be is we insert the sampler that has the collected cells, and then we rotate the sampler in the lysis buffer against the tube wall for 15 seconds at a speed of 1 cycle per second. And before taking the sampler fully out, we will press it firmly against the wall to ensure that we are getting all the liquid and cellular content out. And after discarding the sampler, we will mix the lysate in the tube using a transfer pipette, and this will be ready to be screened on our point of care test. So to validate all these protocols that we've developed, in terms of collection and release, we wanted to make sure that we're going to get the highest cellular and total protein recovery, because as Samron showed, the expression of these biomarkers are not as high as we've seen in the tissue samples. So to do that, we compared some of the most common samplers, including the cytobrush and the cervical broom, to one of the most recently emerged samplers, which is the flock swab. And as you can see on both plots, the left one showing the cellular retrieval and the right one showing the total protein recovery, there wasn't any statistical significant differences between the 3 samplers. That's why we have chosen to use flock swabs to move forward along with the project, because not only it's less expensive, it also allows for self-sampling for patients who don't want a provider to collect the samples for them due to stigma. Regarding the processing and lysing the cells, we developed as I showed on the previous slides, we developed an equipment-free protocol, which means that there are no centrifugation steps needed or any refrigeration, because we will test the sample as we lyse it on the assay. And to show that if this method was effective or not, we developed some dipstick assays based on Ponceau S stain that will turn to pink/red color in the presence of proteins. And as you can see, this is our negative control, which only included our lysis buffer. And you can't see any staining on it, which means that there are not any unspecific color change. And then upon testing our clinical samples, which have been lysed, 3 ASCUS and 3 low-grade samples, as you can see, we have gotten access to the proteins. So with optimizing the process of collecting, releasing, and processing, I will now hand it over to Lucy to go over the assay development and prototyping. Thank you.
Thank you, Saya. So we're going to get started with understanding our conjugation protocol to be able to provide and produce our assays of interest. And we utilize gold nanoparticles at the size of 40 nanometers to provide the colorimetric or color-based readout for our assays. And upon adjusting its pH and utilizing monoclonal antibodies specific to each of our biomarkers of interest, we also introduce a blocking buffer to help prevent aggregation. And following those preparation steps, we use the centrifuge, aspirate, and resuspend in our preferred storage buffer per biomarker of interest for a final optical density at 10 that provides the best stability for our conjugates. And in terms of validating it using a dipstick assay, we utilize a nitrocellulose membrane as our detection method that is striped with our control and test line capture antibodies, as well as an absorbent pad to provide the wicking behavior and allow the sample to wick up the nitrocellulose membrane when it is added into our conjugate solution that is prepared, whether it's in an Eppendorf tube or well plate that already has our conjugate with the protein present. And that after 10 minutes is removed from the Eppendorf tube or well plate and provides the readout of your test and control line as seen on the right-hand side. In order to better understand the range or antigen-based detection of it, we wanted to look towards limit of detections for each biomarker. And this is just an example of one of them, and in this case, MCM2, where we're looking at both pre and post signal enhancement. And given the sensitivity of antigen-based tests needing time signal amplification, TMB, which provides that blue chromogenic color shift, is what's used to help validate this improved signal intensity. And that can be seen here on the images on the right-hand side, as well as the decreasing limit of detection of, at the time for MCM2, 1 microgram per mil, but other assay developments across this project have achieved limits of detection as low as 20 nanograms per mil. And with that, we still are looking to translate this to a lateral flow assay design or format. And in order to do that, we've already accomplished different preparatory steps to assemble and fabricate these assays. And so we've already explored what the nitrocellulose membrane is prepared using, with the test and control lines striped at different locations and optimized for its optimal band intensity, at times blocked as well to provide a improved non-specific binding platform. And then we also need to translate those conjugate solutions that were stored in Eppendorf tubes or well plates into a dried down or lyophilized version for our assay development. And then lastly, if and when needed, we can pre-treat our sample pads to help with any sample, to help with normalization of the sample upon being added to the assay. So once assembled, an example of such is shown below. But we also want to start to explore how to detect multiple biomarkers as shown in our project proposal. And so utilizing a potential duplex assay design is one starting point. And using a backing card that is more of a unique branch shape seen here, we can incorporate nitrocelluloses for each specific biomarker of interest, conjugate pads that are specific to each biomarker's monoclonal antibody to provide optimal detection again per biomarker. And the absorbent pad that we featured earlier for the absorbent or for the dipstick assays reintroduced here for the wicking properties, as well as a unique design for the sample pad that is optimized for the sufficient reagent delivery to the detection region. And an example of such is shown here, where while it does show just MCM2 antigen detection, we're exploring the differences of our conjugation protocols, which earlier mentioned is our passive absorption procedure shown on the first slide earlier. But compared to branch B, which is our NHS activated based off of covalence binding, to determine if that has a stronger binding affinity at our test and control spot in this case, as well as trying to optimize what our conjugate pad itself is prepared at. So optical densities or the degree of saturation of the conjugate pads is also compared for optimal result interpretation. And with that, I want to carry it back over to Saya for her machine learning results interpretation.
Thank you, Lucy. So why do we need to use machine learning? So since we're planning on using multiplex detection, yes, that will increase our sensitivity and specificity. However, having multiple test lines would make it difficult for the user to interpret whether this is a positive or this is a negative result. Also, we are trying to see if we can also classify the grades, meaning can we classify the low grade versus the high grade samples. as well as the fact that, as Samron showed, we have high protein expression variability patient to patient and case to case. So that's why this will make it kind of confusing to interpret the final result. And to kind of solve this problem, we and allow for accurate and reliable results, we are going to leverage supervised machine learning based and particularly classification problems to eliminate this issue. So in order to do that, I'm going to explain some of the terminology here. We will have some input features, which would be our test line signal intensities. So basically similar to what Lucy showed, the intensity of the test lines should be quantified, and those will be our inputs. And then the outputs would be our cytology categories that we will use to validate whether our test is accurately predicting and detecting the sample. And so in order for us to actually get the signal intensities, we will need a colorimetric reader, which involves an assay holder. This will allow for consistent imaging across case by case and assay to assay. And second, we need a confined dark space with a controlled light source so that we would avoid any shadowing or any difference in contrast. And the light source would be, ideally, we are trying to use a flashlight of a smartphone, of which the camera is also going to be used to take the image. So this will allow us to perform on-device image processing and classification powered by Python and its inbuilt libraries such as sklearn for machine learning and other libraries for data processing such as NumPy and Matplotlib. And with that will allow us to actually assess the predictive power of our model and predictive performance using metrics such as accuracy, sensitivity, specificity, precision, or the F1 score, which is a more objective metric that involves both precision and sensitivity. And this will show whether the target that has been predicted, does it match with the ground truth, which is the cytology categories. So with that, we presented from actually identifying the markers, quantifying them, collecting the samples, releasing them, processing them, onto actually testing it on the assay, and finally interpreting the results. And with that, I will hand it over to Dr. Mohammed for the final remarks.
Thank you, everybody. So just to summarize what we have told you so far, that this is a collaborative initiative to develop a lateral flow based point of care test for early detection of cervical cancer. Our ServBio, that project, that test we are preparing, we call it ServBio, and it involves Purdue University of Florida, and Zambia Cervical Cancer Prevention Program. And why is Zambia Cervical Cancer Prevention Program? Because Zambia have established a very big screening program in Zambia. And they have many centers that are covered by that, and they're using VIA. And this is been established long time, and this is why we are collaborating with them. And as we said, that test we are developing, that is not only for low and middle income countries, but also it can help. It can be used in the rural areas here in the United States. So our test, is used, as Saya and Lucy has mentioned, is that it uses a lateral flow technology, same as pregnancy test or COVID test. And, as in COVID test as well, remember you have to take a swab from your nose and put them in a tube to solubilize your sample, and then you put it in the lateral flow. So it is the same idea. The woman can do that at their home, use one of the swab that Saya talked about, and that to obtain her own samples, and that then she put it in a tube and apply it to the lateral flow, and hopefully by using her cell phone, she can see or can interpret her result. So this is, as we said, is very innovative approach, And as Jackie said, we have been funded by locally here at Purdue with few initiatives, and then finally our project is currently now is funded by NIH, so we can close the gap in cervical cancer, not locally but worldwide. So next slide, please. There is, in addition to us, there is other people who are working this project with us, and we collaborating with them. That is, unfortunately, they could not make it during this time. When we, like today, when we had this seminar, so they have other commitment. We have Dr. Scott, who work a lot in our chemistry work. And then we have Korsbeck and Leah, who are Dr. Korsbeck, especially, who established the cervical cancer prevention program in Zambia. And then we have our collaborator, Lisa Flower from Emory University, who provided us with all the cervical swab we used in this project. In addition, we have joined lately in University in Florida by Dr. Syed, who is going to address the multiplexity, to do the multiplexing of all our sample. So if you have any question, I will open the floor now, and thank you for you guys for presenting this. Say Jackie, Sammons, and Samreen, and Lucy. So we can take any question.
I believe there's already a question for you in the chat, ma'am.
I wonder to know, please, if before doing the screening, is there any retrospective study on cervical cancer in Zambia that describes the incident in the past 5 to 10 years? For instance, is there any local registry instead of data from IARC? That does not really describe the reality on the ground, but only potential incidents. Samson, can I give you that question?
Yes, thank you. Thank you, Karim, for asking. So yes, there have been local studies in Zambia that speak to the incidence of cervical cancer. In fact, the IAC data that I have quoted and presented here aligns 100% to that the local information. The local data also goes further to rank cervical cancer amongst other cancers. So the IAC data is as a result of information that was obtained locally in 2021. And as you know, the the Global Con report was released in 2022. So this data is as is on the ground here. Further, I wish also to say that in terms of admissions to the Cancer Diseases Hospital that attends to various cancers in the country, cervical cancer ranks the first. 30% of cases that were seen in 2021, 2022 were actually cervical cancer. So in short, yes, there's local data and the quoted data here, although it's from IAC, but it's actually exactly what we have on the ground. I thank you.
All right, is there any other question from the group? Okay, so I think there's another question. So it's from Francis Makaka. Thank you for this great innovation. However, will temperature variability impact the kit?
I can defer that to Jackie.
Unfortunately, Dr. Linus had to step out of our call, but we're happy to pick up that question from the Linus lab side of things. And yeah, currently we have not gotten to the point in which we are doing temperature testing and in terms of our final stability of our product overall. However, we are incorporating stability testing in general throughout our procedures, both in conjugation and in assay preparation. So we're really focused on controlling the humidity and temperature while doing the preparation and understanding what the range would be for a tolerable assay performance. And there are also like accelerated stability studies that we're going to implore so that we don't have to have an extended wait time to investigate these concerns. Does that hopefully answer your question?
Hope so.
And thank you.
All right. So while we're waiting for other people to ask questions or raise their hand, I think I have a question. And so my question is in three parts. So the first thing is I don't know if you, of course, you know about Genespad assay in the breast cancer space has been seen to be cheaper and easier to be done, quicker and all that. But still, we still have a problem with the implementation of this, right? Even though we think it's much more applicable in MMIC compared to the IHC molecular diagnostic testing in breast cancer, there's still reduced uptake. Right. So the question I have for you is that with your testing, right, is this something that is applicable within the continent? And as you're developing it, is it cost effective? Meaning that I would like to say comparison of the cost of what is on ground and what you think the cost might be. And then as you're developing it, how easy is this to be replicated in all laboratories, whether you need a lab or whether you need a person that needs to be much more trained to be able to do this, and how applicable is it within, let's just say, an institution with, or local institution within the continent that has little or no skilled workers.
So, Ebola, your question is three parts. So the first one is the cost.
Yes.
And the second one, how we implement it and people can accept it, acceptance.
Yes.
And the third,
one is the training of the people, within the continent,
Oh, so regarding the cost, so we are hoping when we manufacture it, that it will not cost a lot to do because it's just a membrane. So we were looking at that cost, and I have collaborated with industry before, but I did not pursue it yet, that this thing could be manufactured at low cost. And even if it costs $1, we hopefully to advocate for it so that even WHO, if they exist by then, to subsidize it for low and middle income countries. Regarding acceptability, I think COVID test and pregnancy test, everybody has been using it now without too much fuss. But I know that cervical cancer is something a little bit sensitive. So we are hoping that we could launch some, um, uh, some awareness in Africa for people how to use it, or maybe we'll start first by giving it to the hospital and the clinic, and then that can be provided to the patient. Regarding training, we are hoping this test will never need training. This is why we're trying to work it to be friendly, to be user friendly, and that we could people can use it, or even the nurses in the clinic can be able to use it. And we actually conducting, we are doing, what's call it? Samrim, would you please help me? That we are trying to see feasibility of this when we're doing the survey with
Yes, yes,
somebody
that's
can
right.
jump in.
Yeah, we are currently preparing for a feasibility study to go over how this will be visible and what will be the good way. But this feasibility study, for now, we are targeting the health worker at Zambia Center. So we will start among health worker and all the provider. Then we will take it to the patient level. So, but for now, we will start with health provider in Zambia. And Lucy and Saya, you can add if you have any addition to me.
I think we have a question, but before you read the question, I think I just want to make a statement. As far as manufacturing is concerned, I hope that the plan is to manufacture within the continent, because then labor is cheaper in the African countries, and it's going to help with distribution of those tests. And hopefully the goal will be to make this test available to at the point of probably less than $1 a day, like 50 cents, because that's because we're thinking that a lot of people live below poverty line. They live less than $1 a day. So we might have to start thinking about as we're thinking about all this innovation, if pharma is involved or industry is involved, it becomes very expensive. So we have to start thinking about things that was done by Africans, and hopefully we can take it back to our continent and be able to manufacture it. So
yeah, we have actually we have collaboration with some people from industry. I don't want to say the name now to commit, name, but we are talking, and they are located in Eritrea, and hopefully we will work with them to manufacture this for us.
Okay. Within the continent, all right.
Yes.
And you can bring it to Nigeria. Just
It's
so
submitting an IRB to send to healthcare workers in Zambia, mostly because first we wanted to understand if this is what they want to do and if this is going to be helpful to them, because we have been receiving different opinions about some providers actually agree that VIA is working very well, but some agree that it has low sensitivity and specificity. So first, this was our first stage. And as Samron mentioned, we will move on to the patients afterwards. So to answer your question, we still haven't tested this on any patient, but that's the goal to be able to do that. And another thing that I wanted to mention was our goal is to achieve the sensitivity and specificity of Pap smears without the need to do a co-testing with HPV, because sensitivity of Pap smears for precancer is low, and that's why HPV testing was introduced to kind of compensate for that. And currently, with most of our biomarkers, when we did the quantifications, some of the results that Samron presented, we have been able to achieve a sensitivity and specificity of 90%. So that's also promising. So the next step is to be able to achieve that also on paper, meaning on the paper-based assay. And once we get to that point, I think we would be able to actually initiate the process of screening it with patients, if that makes sense.
thank you.
Yeah.
Good job.
All right. So Professor Chris Williams sent a message congratulations to the presenters of this highly innovative study. The Servio project has a high potential of being a game changer in cervical cancer control. Special thanks to the leader, Professor Salma Mohammed. So thank you for that. So we have the next question from Antonio Lento. He thought this was a very innovative project. What is your take on the psychological cost of self-screening if the goal of the project is to make this test available to the public, meaning accessibility, especially issue of sensitivity and specificity highlighted?
So we are hoping that we, as Saya said, and everybody shows here, that we have about 90% sensitivity and specificity. So hopefully, that is a good question about the psychological effect with everybody who is, went through false diagnosis or accurate diagnosis. We all feel not happy about it or very nervous about it. So hopefully our test will do it so that we hope that will not have a lot of negative, false negative or false positives. Yeah. So, but that's something maybe we need also to address.
Yes, and I agree I agree to that. And I think especially with the swab choice, that was one of the reasons why we went with the flock swab, to also allow for self-sampling if needed. But I agree that we need to have like clear protocols for the patient and like user manuals to be able to sample themselves correctly so that they don't have any um, sample inadequacy. And something that we are also trying, and it is also included in the IRB, is that we want to make sure that if they get a negative test, the similar approach to the PONSOS dipstick is going to be used to validate whether they had enough samples to begin with. So if they did, then that means that the test was actually like a true negative. And if the sample was not enough to begin with, that could be a false negative, and they need to repeat it to get more samples. So that's an approach that we have in mind, and this is something that, again, we're trying to kind of collaborate with the providers in Zambia to see if that's something they want to work with, and they are willing to take the time for it. So, and as for the timing of the test, the actual assay will take around 15 minutes, but if they need to do the validation for PONSOS to validate whether the negative was false or true negative, that will also add an additional 10 minutes to this test. So a total of 10 to 25 minutes, that would be the time of the assay.
Thank you very much. So we are reaching the end of the hour. Thank you so much, Purdue, for an excellent job and sharing your research work. We hope to see you again at some point in the nearest future and presenting the new things you're doing. So quick announcement. April 26th, for people that are coming to ASCR in Chicago, we have during April 26th, we have our aortic networking. It's 6 to 8 p.m. Again, I want to recognize and thank Professor Chris Williams for funding this session with us. And then May 31st, we have aortic networking session in during ASCO. That's going to be May 31st. That's about 6 to 8. Then in June 27 to 28, we're going to be having our first in-person Best of ASCO program in Ethiopia. We hope you should attend. We will be sending invitation to that. Please plan to attend. Is on the continent, and we are going to be also be talking about Africans' access to innovative therapies, technology, and resources. It's a must for us to attend to show that we actually know the data and we need to actually shorten the time with which all these innovative therapies, immunotherapies, targeted therapies gets to the continent. Then July 22nd, also 22nd to 24th, it goes back to Ghana, the basic scientists amongst us. They are actually having a presentation. Oh my goodness, it is so technical. Let me see. So the theme is catalyzing basic and translational cancer research in Africa, advancing progress and capacity building. So next month, same time next month, meaning that first Tuesdays of every month, the month of May, we have UCSF will be presenting Professor Lawis to everyone, great presentation. And then Teresa Dix-Peak, thank you for an interesting presentation. Okay, so so they will be talking, UCSF Tanzania Cancer Collaboration will be, their topic is addressing critical evidence gap to strengthen cancer care in Tanzania. So it's May 6th. Please join us in the Aortic North American series, part 8. So do you have anybody that has any announcements that wants to share this in the group? We have like 4 minutes. Anyone who wants to unmute themselves to share whatever the innovation or announcement or anything project. We also have the aortic ASCO International Research Program. I think everybody should have seen it by now. Please apply, apply, apply. We need to be able to continue to do this every year. Okay. Thank you again very much for attending. I really appreciate it. And I think that, oh yeah, Aortic 2025 Tunisia. How would I have forgotten that? I would have been fired.
I was about to say it, and we have a local organizing committee chair in the audience as well, Karim Khaled from
Right.
Tunisia.
Karim, thank you for joining us. Tunisia. So we are all going to North America in November. And for those of us that has not been there before, we'll be branching there from Tunisia to Turkey to Dubai and doing all that stuff. I think Eric will be paying that. No, I'm just kidding.
You're almost welcome to visit our really beautiful country.
Yes. So yeah, and the essence of this kind of presentation is for us to foster collaboration. Antonio, yes, they are open to collaboration. We are all open to collaboration. So we want to foster collaboration. Everybody should know what everybody is doing, right? And it's always very interesting when we join this. Balmora, can you please please help us with Antonio's email so that we can share Professor Salman's email with him and make that connection for them. So thank you again, everyone, for joining. And the lack of anybody saying anything, we will be ending the meeting for today and giving you 2 minutes back of your time.
Thank you.